I'm Ken Wells, and I'm linking my arm in your arms as a witness for wellness.
My name is Loretta Jones,
You want?
and I'm linking my arm and your arm as a witness for wellness. What I want you to do now, because this is very important, I want you to touch the person next to you, and I want you to link arms with someone else and say, I am linking my arm with your arm as a witness to wellness. Now, the reason why we do this, it's really important. It's an activity that helps level the playing field. Because what we believe is that when you bring community and academics together, that you need to have something that levels the playing field and allows both people to do something that is equally as important. And of course, we use Witness for Wellness because we believe in resiliency rather than the deficit model of disease. So we want to give you that for the first time. Ken?
Yeah, and just to add that with this conference, Senator Steinberg's vision, Rusty's vision of connecting the counties, the academics around some of these critical issues, early psychosis disparities, and so forth. So today is it's happening, right? So rather than thinking of all the work ahead, we are now on the road. So I want to thank Cam and Fred and Davis for, and our chair Peter for this beginning of a new vision.
Now we're going to do an activity to have fun because you've been talked to a lot today. So now we want to play because I believe that play is a part of work. And that if you play with each other, you tend to break down those walls that prevent you from talking to each other and telling the real stories. So I want someone to pull out their keys. Does anybody have their keys with them?
Not this key.
Not
your
this
own
key,
keys.
your keys. And then I want you to tell me what you have keys to. You can shout it out. Who has a key to what? You have, oh, you got a job.
Got a job.
And you're trusted. Wow. Oh, you got a house. Oh, yes, you're not homeless, huh? You got a bicycle. You're taking care of the ecology and the earth. That's so great. You're loved by someone and you're trusted by them. That is so great. That means you're caring for someone other than yourself. The Marriott. You had a place to sleep tonight or last night. A bottle opener, yes. How many people have loyalty cards on their keys? You know those are loyalty things? Yes, you have those. That means that you can go to the store and get discounts. And then you have keys to your mailbox, and you have keys to a car, which means you have transportation, and you have keys to other things. So when we talk about who has keys, now I want to ask you who doesn't have a key. Shout it out. Okay, who else does? Okay, who doesn't have keys out there in the world? The homeless,
Inpatients,
inpatients,
rehab programs,
prisoners, the president, you're right.
kids. Was that
Children. Okay, some of the other people who don't have good keys are people who have lack of access to good health care. That's a key.
a metaphorical key, right?
If you don't have access to education, that's a key. There are other places that you have no keys. So when we talk about what we're doing here today, one of the things that you're doing is you're speaking for whom? On page 22 in the book that you have today, it says you're speaking for the voiceless. You are the voice of the voiceless. And so what this key is for is to remind you that you put on your keychain and you see it has no grooves on it. And this is a key that wherever you go, you are reminded that you must speak for those who have no voice, those who are not in the room, community members who you didn't get to come today, the nurses, the patients, the politics. You are their voice now. And you are the voice of people who really need to be heard. When we talk about psychosis and we talk about people who have psychosis, we need to talk about what it feels like. We need to tell people what it feels like so that they understand and have compassion for the folks who have no key. so that we can actually do the services and plan things with people that make a difference. So I'm asking you to take this key and add it to your key ring. And so that when you go out into the world, you'll have this key. And as a reminder, you'll pick up your keys and you'll say, oh, yeah, I'm supposed to talk for the homeless. Yeah, I'm supposed to talk for the people who have no education today. Yeah, I'm supposed to talk to someone who is a patient and who can't speak for themselves because they're in psychosis. So that's what we want to do for you today. We wanted to start that off so that you could understand what it means to level the playing field and to be a part of something bigger than yourself, reaching out and reaching back and reaching forward. Now, we have slides, and we're going to go through some of these slides very, very quickly because I realize that you're tired and that it's been a long day, right? And so I'm going to first talk about what we've done. We have put together a process that leveled the playing field, 12 years ago, 13 years ago, where we became friends and started working. If it hadn't been for Dr. Wybrow, who is my pal, because when I first met him, I was scared to death. And I thought he was going to eat me alive. And guess what? He was the kindest, friendliest person. And then there's Sergio. And Sergio and I have talked back and forth and been on panels together for so long. And we now can actually speak each other's voice. So when I'm not there, he can speak the voice of community now. And I can sometimes speak the voice of academics. So we're going to talk about what we've done and how can you translate the benefits of high-quality depression care into better lives for under-resourced, and you hear the word under-resourced communities, not disadvantaged communities, but under-resourced communities. Because it's really important today to talk about how you speak as well as what you do. You know, like using the word subject. We all know that's a bad word, right? Do we know it's a bad word? How come that we all allow the government, NIH, God bless their people in the hearts, that they take and put out RFPs, and what do they say? What's the subject population? Not what the participating population is, but what the subject population is. So if we don't change things, we're going to continue doing things the same way, so we don't want to do that. We all know the history. We know the history of Tuskegee, but we also have communities who know the history of the tragedies that happened in mental health. And we don't talk about them, but they're there. And we need to be able to take and acknowledge them when we're working with community. We need to talk about the things that they used to do to teenagers in treatment centers in the late 50s. You know, what did they do? They actually took them, gave them shock treatment. They gave them, I think it was insulin or something, and shocked them to take and change their behavior. And they actually made vegetables out of some people. But we don't talk about that. But communities know about it. And so when you talk about Tuskegee as a bad historic thing, and they say, yeah, but what about some of the other things that happened with mental health? What about the people who were tied down for days on end, locked in seclusion rooms, hung themselves because no one was watching them? So we have to talk about all of those things out in communities because it's really important. We also have to take and talk about the distrust in our government, because sometimes we wonder, why is our government doing things for us? Particularly people of color want to know that, since for years historically they didn't give us anything, and now all of a sudden we are the best patients in the world, and people want to know, well, why all of a sudden you're talking to people of color? We've been around for 100 years and you didn't talk about us. And then you also want to talk about how community-based participatory research approaches are recommended to build trust, because you want to be able to take and look at, how do you build trust in communities? How do you put your foot in your mouth and take it out? Because sometimes we go to communities and we put our foot in our mouths. And I go to the academic institutions and I talk about the researchers who should keep their butt at the bench and never come in the communities, because I know that when they come to the communities, they're going to screw it up for everybody else. So, you know, I talk about that, but I also have someone to help me get my foot out of my mouth if it's really bad. And the other way around, when you go to communities, they say, you people, you all, those people. You know, we talk about those things. So we're trying to take and build trust. And how do you build trust? With the structure that we put together of community partners in care, we actually did CPPR, community partnered participatory research. That's very different in a way from community based participatory research, because one of the things about community based participatory research, there are several kinds to it. One of them is I'll get an advisory board of community people, and then I'm going to call myself a community partnered participatory research project. Some of them say, well, I'm going to go into the community and I'm going to put UC Davis up on the wall. And I'm going to say, here, I'm in community, and they bring their own staff. Or someone will say, well, we'll hire one person from the community, low man on the totem pole, because of course there are no PhDs in communities of color. Did you know that? I hear a few people knowing that. But did the rest of you know that? Talk to me, please. No one's going to answer me, huh? Yes. Uh-huh, see? We know people, and we know there are people out there, but when it comes to hiring them, sometimes they're said, well, there's no one in community can actually do this work. And that's not really true. We have to look for the folks. So anyway, we talk about, I talk about the vision, the valley, and the victory. And I'm talking real fast, and I hate talking fast because I think I always miss things. But everybody has a hand. Put your hand up in front of you, please. Look at your hand. Do you see the kind of V's that are in your hand? There's a V that we call vision, and a V that we call valley, and a V that we call victory. Now, the vision is if you, the researcher, and the community come together and you all are on the same page, that's a vision. But if you're on that page and the community's not, there is no vision. Now, here comes the valley. And in the valley, if you work and the community doesn't do anything, you're going to be real pissed off, aren't you? But if you ask the community to work and you don't work, I'm going to be real pissed off. Might not want to talk to you anymore. And then here's the victory. Keep your hand up because you need your hand, because this is your learning tool, and you can take this away with you today. This is the, it is. This is the victory. I talk about win-win. We have to have a win. If the community wins, that's nice, but if the researcher doesn't win, they're going to be pissed off. And if the researchers get their papers out and things and the community gets nothing, they don't get any data back, they don't be able to do anything, they're going to be pissed off too. So here's your vision. You work together. Here's the valley. You do it together. And here's the victory. Everybody wins. And if you have those three V's, here's your last V. It's a value. You can take this and teach your whole classroom. You can teach other researchers how to do this work. So you can put your hand down now. But remember, this is your tool, and you can use it anywhere you want to go. These are some of our partners that we have, and I have to tell you that those are only a few of the partners up there. We always try to take and make sure that we give homage to the people who work with us. And when you're out doing this kind of work, you really need to make sure that it's not just the universities that's name is on paper, that you have to put the community's names up there as well and their logos, and let people see when they're sitting in the audience, oh, look, there I am. So that's kind of what we want to do. And Ken, do you want to talk a little bit more? We have, what, 95 programs that we worked with?
Yeah.
Yes. We worked with 95 programs on the CPIC project.
I just want to add, because I think I left the slide out, that the key aspects of Loretta's engagement model really are the principles. And the principles are equal power sharing, so that everyone, it's not like I have control of the budget and Loretta's advising me or something like that. We both equally power share, as well as the entire, if you were the council over one of our initiatives, we would all be deciding together, we'd be voting. We might not always agree on everything, but that's fine. We would still vote and move forward. So that equal power sharing, two-way knowledge exchange. So I have things that I know, Loretta has things that she knows, you have things you know, and we're exchanging knowledge. We're not one over the other. Trust and respect development. And it's really those values, using community engagement activities, keys, and so forth to make that a living principle in the work that you're doing right now that I think makes this work.
And there's one big one. The big word begins with a T. Anybody know what it is? Transparency. It has to be transparent. You cannot have these sidebar meetings before you go to the community. You know how some people have, let's get together and we're going to talk and work on what we're going to say to the community, how we're going to work the community. Can't do that. This kind of work says that you have to have an equal partnership. This kind of work says that if you want to take and tell the stories, and that's what everybody's been saying today about telling the stories, you have to be able to be transparent and tell the stories. You have to remember that there are PhDs of the sidewalk. How many people know what a PhD of the sidewalk is? Sergio knows. Anybody else? Yes? What is it?
Yep. Your experience on the
That's
streets.
right.
Right.
And we have a lot of people in communities that have maybe 2 or 3 PhDs, if you want to think about it. And when you go into the communities, you have to recognize and respect those PhDs. Even though they didn't get them in an academic institution, you have to remember that they're there. This is our plan.
Right. So one of the reasons we were asked to talk about the Community Partners in Care project today is, which is not an early psychosis intervention, though we had about a third of the sample had high risk for psychosis, and we'll talk a bit about that. But the reason is, here we are talking about how do we move forward with programs that you may be doing for the Mental Health Services Act, you may be doing under other state or county funding. It might be a services demonstration, it might be a research project, but we're talking about doing it in a somewhat different way and for a different purpose, which is to both help the population but also learn something about impact. So that brings in that kind of opportunity for rigorous evaluation so that you can actually say what was accomplished. So that means doing it in partnership, right? It's not the evaluators kind of coming in and, oh, we're watching while you're doing something. It's really how do you do all of the work that we're talking about here today in partnership and also collect those outcomes data. So following the framework of vision, the valley, and the victory, during the visioning phase, we have groups like this that are both the community capacity. Some of you are services providers, there are some community members, some patients, family members here, and academics all working together around a shared vision. In this case, for today, early intervention in psychosis. That would lead to some kind of partner demonstration. You're either looking at one particular approach or a set of different approaches. It's also come to some agreement as well as the outcome selection, like Howard was talking about in terms of working with the community, and then using those results, having the policymakers also at the table. We have some of that today, so that the results can more easily get back into the capacity of the agencies and the community. So it's like thinking of that framework, not just for research demonstration, which is what our example is, but for broad work that's dissemination in the community.
One last thing on that one was the dissemination of information, and it's required that you disseminate information back to the community and to the total community that you work with and others. And you do that sometimes by having, what we do is free conferences. We take everything back to the community as we have our findings. We had our 6-month findings, we took them to the community. We had our 3-year findings, we take them to the community. So the community actually has we also publish together so that, and we do the analysis of the data together so that it's not just the academics analysis, but it's the academic and the community's analysis. Because sometimes words change. Sometimes meanings change between things. So, and also the instruments that we use are vetted through the community as well.
This particular project, I'm going to go quickly through some of the design and result features because we are going to try to actually end at 3:45. So we're shortening our presentation just so you can, so this took place in South Los Angeles, Hollywood and downtown, which is about 2 million individuals. Los Angeles County has 11 million, and this is 2 areas of the county that have about 2 million individuals. And we worked in community forums, in movie theaters, in churches, and so forth, to really discuss, given the issue, in this case that we were talking about depression, where do people talk about and deal with their issues? Is it with a doctor? Is it with, and what we heard, which didn't surprise Loretta, but it surprised me, it's the barber, the hairdresser, the minister, the social services provider. So we ended up including 95 agents, the senior center, the exercise club, Curves, as well as for some people, the primary care doctor or their substance abuse provider or their mental health counselor. And then these programs were randomized to one of two models of doing best practices for depression. One model was bringing everyone together and doing that planning and engagement about how this great diversity of agencies would work as a network, or one agency at a time, each agency getting technical support, which is usually how quality improvement work is done. Technical assistance to agencies with engaging them rather than having them thinking across the silos. So it's sort of across the silo or agency by agency. And I'm sorry, I'll go back for a sec. And then within each of these 95 programs over a 3-day period of time, for purposes of tracking outcomes, we took people who showed up at the door, whether they were in a food line, if it was a homeless, there might have been a food line in a homeless shelter, or visiting a doctor in the waiting room, or coming to a prayer meeting, and screened them for depression, about 4,500 individuals. And actually, with all of the community engagement approach, 95% of people approached agreed to be screened, and 92% of people who were depressed agreed to be in this randomized demonstration. And that, I think, is a tribute to the extraordinary input from this process. And then we tracked people, just whatever program they happened to walk through. They were not routed into a care model. It's their program was supported in a model at 6 months, 12 months, and we've just completed 3-year outcomes, which I think we're sharing a little bit for as a sneak preview. This is the community's version of the design. You see the randomized coin toss. We did extensive work on how to frame randomization in the community, did votes, shared presentations together, and you see the diversity of programs either alone, one by one, being supported or connected in a network through a planning process over about 4 to 6 months, again in a room something like this, with all of those agencies represented, deciding, do we need MOUs? How do we need to modify CBT? Does it need to be more strength-based? And then work groups developing those modifications for the network over that 4 to 6 month planning period. Whereas the other group got 12 webinars and some site visits on each component of the depression model.
One of the important things that we need to let you know is that everything that we did with community, all of the trainings that we did, they walked away with all of the materials. Every agency had all of the screening materials and all of the CBT training modules, how to do the work, everything. That, again, is transparency.
Yeah, there is no usual care. This is just everyone is getting best practices. It's how you get it. And just very quickly, these are components of the toolkit: case management, cognitive behavioral therapy, medication management, and some community modifications, resiliency classes that the ministers developed based on CBT, alternative health practices that the community asked for. This is the key exercise. So one of the things the community asked us to do is they wanted to know every single place in the community that every person was trying to get help for depression over the 6 months before they came in to this demonstration. This is one homeless person, just to show the example of the problem, screened in this homeless shelter. And these are all the places this person was trying to get help for depression. You can see the primary care. That's 55 minutes away on the bus in no traffic in LA, which doesn't exist.
Don't forget he has no money, he's homeless.
He's homeless. Mental health services, social services on the beach. When we asked this person, why are you going this far away? And we did that because the community asked us to follow up with every person who expressed suicidality, and this person did. So we had an opportunity to kind of discuss with him what was going on. It was because he felt trusted and respected at the social services at the beach, even though they were right across from his homeless shelter. Now, you can imagine, what does it mean to integrate? How does a person decide what they're going to do around their depression? What are they hearing from this place or that place or this place? How does that become a plan, right? And that's part of why that stimulated the idea of doing a network-based approach that pulled all these sectors together so that people would kind of be saying something like the same thing. And very quickly, this is an overview of the 6-month findings, which have been published. And both groups got better. They both had support for evidence-based care. The community engagement group got more improvement in mental health quality of life, which was our primary outcome, and in homelessness risk factors, increased physical activity, and a 50% reduction in behavioral health hospitalizations relative to the other best practice group that was just receiving the technical assistance, and shifted more of the outpatient visits toward community visits, whether it was primary care, the senior centers, the faith-based programs. There was no difference between the groups in depressive symptoms or technical treatment for depression. So, but they're both getting support for that. So this difference is not more formal treatment. It's what happened outside of formal treatment in these broader networks. This is an example of what happened to the subsample that had psychosis. And you can see the reduction in poor quality of life at the 6-month time point for the 419 of the 1,200 that were either bipolar or had been hospitalized for psychotic symptoms. This is an example of the homelessness findings. And this is the reduced homelessness risk in the psychotic, in the group with severe mental illness, the subsample. And this is the hospitalization reduction. You see that 50% drop, whether it's any or more intensive, and also in the severe mental illness sample. At 12 months, there was continued improvement in mental health quality of life and reduction in hospitalizations. The startup costs are more for the community engagement arm because more people come. And it's not so much that the model is more expensive, it's we're accounting for the time of people like yourselves to come and be trained. That costs your agency something. But there's no overall difference in healthcare costs. We've just finished 3-year outcomes, and we're seeing actually 3 years later, we go away, the patient may not even be anywhere connected to the same, it's whatever they learned 3 years later. And there's some improvement in physical health under the community engagement model. There are still overall fewer hospital nights in the community engagement model, higher connection to the community, higher use of mood stabilizers, which is probably important because the large share that's bipolar. This is showing you what happened on the healthcare sector side is there was a difference in what door you came through. If you came in through the church or something like that versus coming through a clinic. If you came through the clinic, you were still more connected to the community 3 years later. You were still more in the faith-based programs, you had more community supports. If you came in through the social community side, you had a considerably higher rate of appropriate depression care 3 years later. More antidepressants, more primary care visits, more connection. If you look at the numbers, it's more like they became like healthcare patients, starting off in the church, whereas they might not otherwise have had access to healthcare for this mental health condition. And there are lots of other benefits in a project like this that we try to build in, the CMEs, matching dollars for grants, and that sort of thing. And what's interesting is with all of the involvement of the policymakers throughout this process, the providers, the agency directors, the head of DMH and so forth, at the report backs, the planning meetings and all of that, is the policymakers got it almost before we did. So before the results were published, the Department of Mental Health proposed to use innovation funds for health neighborhood initiatives to do a similar kind of program, coordinating behavioral health services across county agencies and addressing local social determinants of health. And they argued, if you could have an impact on homelessness, and that was not even, you weren't even trying to do that, it happened, what if we tried to do that? What if we tried to improve mental health outcomes and homelessness? We could hopefully do even better. It happened because you brought agencies together. They got trained how to deal with mental health people, and they did their thing. And somehow homelessness got affected. What if that was our point? And there have been other impacts.
We actually used, we have a mamas program where pregnant women are actually getting the services of Be Rich, which is one of the programs. It's a resiliency program that came out of this, and there's 7 visits, and they get to use their own strengths to help them out of depression. They get to use the things that they did before they were depressed. So we don't add anything in. They don't have to find new places to go. Just go to the places where they had fun at before. If you didn't go out the door, let's see how you can stand up, get dressed, and stand outside your door for 15 minutes to see how it works, and move just gently out into the world again. So it wasn't that they had to get more services other places. It was just utilizing what they already had.
On the science side, this initiative last year won the Association of Clinical and Translational Science Team Science Award. That's a big national award. It's the first time it's been given to anything other than a genetic study or drug discovery study. So that was a big thing. Thank you. And then this year, it also won an international award for the Campus Community Partnerships and Health Award for outstanding campus community partnership internationally. And then Loretta just won at the United Nations Global Leader of Dignity Award, one of 10 individuals around the world for humanitarian contributions, but in her case, also for translating that into science to improve mental health services.
I think that I always go back to who gave us the chance to do that. Dr. Wybrow, I again thank you again. I thank you publicly, because without your support, this could not have happened in the very beginning, because you were the one that believed the community, it was okay for community to come to the UCLA and do the things that we did. And Ken, without him and our arguments and our, oh yes, this is not just smooth sailing, please believe me. We don't agree on everything, but we work it out, and we don't go to sleep angry, and I'm his second wife. But I want to thank all of the people that made it possible. Sergio, you're one of the people that helped make it possible, because coming down to your shop and talking about community engagement was part of it, going to NIH and actually training NIH on how to do this work.
And they funded it.
Yeah, and then they funded it. NIMH funded it, and working with Tom Enso, who said that he was going to be part of the community partnership, and the fact that all of our partners from the NIH, the CDC, and the university and the community all hung in there, even on the worst of times when money was short and people's tempers were raw. We thank you for letting us come today, and we hope we gave you something to walk away with. We're sorry that we didn't get a chance to give you everything that we had, but you have your key and you have your hand. Thank you.